Jonathan.
Thank you, Francesco. Thank you, everyone. Can you see my presentation?
Yes, we can.
Yep.
Okay. So 1 second. Okay, no disclosures, and I just thank Shlomi for being really just with me all along. Neil Fisher, he's a student who was very active in this project. And there's a St. Louis group with Dave Limbrick, who will give a talk just after me for being part of the project that I'm going to present. So pediatric posterior fossa tumors, as you know, most of them are benign low-grade tumors, and the rest usually are medullas and a smaller group of ependymomas. Screening spinal MRIs are very important in the high-grade group, especially in medullas being part of the staging protocols, but also obviously in ependymomas. Regarding leptomeningeal dissemination in pediatric low-grade tumors, they're not very common. I'm talking generally about low-grade gliomas, not specifically regarding the posterior fossa. So they're about 3 to 12%. Most reports relate to chiasmatic hypothalamic originating tumors, but also other low-grade tumors, especially in the grade 2 group. About 30 to 40% are diagnosed concurrently to the cranial tumor, and there's about a two-year gap, between the cranial diagnosis and the spinal spread. But it's been reported to occur even many years after the primary tumor diagnosis. Now, obviously, a child who has a low-grade glioma and has cranial leptomeningeal dissemination is at risk to have a spinal disease too, and he'll need a spinal MRI. And of course, if there are any spinal symptoms or signs, he will need a spinal MRI too. But spinal screening in low-grade gliomas in pediatrics are costly, they're timely, and they need anesthesia, especially in smaller children. And what is the yield of this study? And specifically, what can we say in the subgroup of children with posterior fossa, low-grade gliomas, and no leptomeningeal disease in the cranial compartment? Is there any role for screening spinal MRI? So we conducted this study, which was retrospective and included children up to the age of 18 with a solitary posterior fossa low-grade tumor. Obviously, children with cranial dissemination or any spinal signs or symptoms or any genetic predisposing syndromes were excluded. We had a total of 229 patients. About half of them had at least one spinal MRI, and the rest were followed clinically. Most of the children who did have a spinal MRI had it done during the first 6 months compared to the diagnosis of the posterior fossa tumor. About half of them had it done just in the same setting as a diagnostic scan of the brain. You have here just a general spreadsheet to show you that most tumors were pilocytic astros. Most were underwent a GTR. However, about a quarter of the patients had less than GTR, and many of the tumors had an interface with the CSF pathways. It could have been in the brainstem outside of the ventricular compartment or within the ventricular compartment. When we compared those that had a spinal MRI and the rest of the patients, the data was balanced. So what can we say about this subgroup? First of all, of those that had the spinal MRI, there was about a 1 year average gap between the diagnosis of the cranial tumor and the spinal MRI. 20% had more than one spinal MRI, and there was an average of 1.5 years between the diagnosis of the posterior fossa tumor and the last spinal MRI. Overall, we had 180 radiological follow-up years. Looking at all the patients, we had about 6 years of follow-up, which added up to beyond 1,000 clinical follow-up years. So in both these groups, we had one case, which was the same case, which had both a clinical symptom and a finding on the spinal MRI. And this is the case. This is a 13-year-old who had cerebellar symptoms and was diagnosed with a posterior fossa tumor, which eventually was a pilocytic astro. At that point of time, there were no spinal symptoms. This is an MRI done at the same setting of the diagnostic MRI before surgery, and you see that there's some lesion in the cul-de-sac. This patient was followed. After 1 year, The patient developed right thigh neuropathic pain, was treated accordingly, but never treated for the spinal disease. 7 years after surgery, there was a recurrence of the posterior fossa tumor, which was again resected, again found to be a pilocytic astro. The spinal lesion progressed but was never sampled. I'm sorry, but I have no additional data regarding the molecular profile or Ki67 of that case. Obviously, looking at all the data, we had a limited group size and follow-up. We had no pathology of this suspected case, and we are unable to evaluate any risk factors like molecular profile, etc., because the numbers are basically close to zero. So what can we say? That when should we perform a spinal MRI in a child with a posterior fossa tumor? So I think it depends on the time. When are we talking? Before surgery, we don't really know the pathology. So if we are unsure about the pathology, for instance, cases when it possibly can be a medulla, an ependymoma, so at that point, the child needs a spinal MRI as part of the screening protocol. During diagnostic MRI, if there's need for anesthesia for an MRI and the child, and there's no online radiological evaluation, this is a point where the threshold for a spinal MRI should be low. And if there's a finding, then we do recommend to do a spinal MRI. Obviously, if there's cranial leptomeningeal dissemination, or if there are any spinal symptoms or signs, a spinal MRI should be done. This is before surgery. So obviously, for such a case with cranial leptomeningeal dissemination, there's no question the child needs a spinal MRI. However, here are a few more examples. This is a 3-year-old with a lesion which has a differential diagnosis. And eventually this was operated and found to be a pilocytic astro, but this easily could have been an ependymoma. So this child should have had a spinal MRI at diagnosis before surgery. This lesion has radiological characteristics of a high-grade medulla. This child should have a spinal MRI before surgery. This lesion is probably an ependymoma, and it was an ependymoma. Just as well, even before knowing the pathology, this child should have received a spinal MRI before surgery. This lesion, on the other hand, is of a bigger child, a 12-year-old, and it does not look like a high-grade tumor. It's probably a pilocytic astro. Now, if the child did not have a spinal MRI before surgery, we do not need to push him for that point. We can wait for pathology. The same thing for this case. This is a case which does not have characteristics of a medulla. It's outside the ventricular system. It's most probably a pilocytic astro. And if a spinal MRI was not done before surgery, it can be done if needed according to pathology. So when should the spinal MRI be performed in posterior fossa tumors? Once there has been already surgery and we know the pathology, we know it was a pilocytic astro or any other low grade. So obviously when there's a new cranial leptomeningeal spread, and the same if there are new spinal symptoms, these cases obviously need a spinal MRI. However, for residual cases or recurrent tumors, there is some data suggesting that they are at a higher risk to develop spinal spread. There's not enough data to comment anything solid about this condition. Now, should we wait for a child who had a cranial MRI and showed a posterior fossa tumor, and we don't have a spinal MRI? Should we wait until surgery, until we have the diagnosis regarding the spinal MRI? So it depends what the MRI looks like. If it looks like a high-grade tumor, then no. The child should have a spinal MRI before surgery, because we do know that after surgery, a couple of weeks may go until all the blood products and other artifacts may absorb and disappear. They may be incorrectly diagnosed as a spread. When is there no need for a spinal MRI? So if it's a solitary posterior fossa low-grade tumor that was completely resected, there's no cranial leptomeningeal dissemination, no recurrence, and there's no spinal symptoms or signs, these children can be spared for a spinal screening MRI. Thank you.
Go. You there? Okay. So anyway, I think he's up somewhere. But yeah, thank you very much, Jonathan. Waiting for questions to come in. So you are saying that if I may ask, so basically, if it's a single solitary posterior fossa tumor, low-grade glioma, or suspected, you don't do a pre-op MRI if you suspect it's a low-grade glioma.
Well, once again, if it's a small child and he's in the machine and someone calls us up and tells us, look, there's a posterior fossa tumor, just recommend to finish up the spine. But if it's a non-anesthesia procedure and the lesion does not look like a high-grade tumor, I think it's legitimate not to do a spinal MRI unless, once again, there's any leptomeningeal disease in the cranial imaging.
Right. So then this comes back to the question that's up here. So says leptomeningeal dissemination is encountered in many cases of pilomyxoid spectrum astrocytomas. So what do you think about that? So this is obviously after you have the histology.
So first of all, as you said, after we have histology. Second, the pilomyxoid is part of what usually goes to the chiasmatic hypothalamic group. And like I presented, they are at a higher risk to leptomeningeal disease. In the posterior fossa, it's much more rare. We did not have any pilomyxoid in our group, so I cannot comment on that. The vast majority were pilocytic astros. So obviously, I think it's especially for this subgroup.
Okay. Right. Okay, I think that's since we're here, I'll just ask you one more question. What about those, say, cervical medullary type tumors, some of these low-grade ones, gangliogliomas and other tumors? Do you actually do a full workout on those or maybe just once?
First of all, there are not so many, and usually as part of the evaluation, they already get a cervical spine MRI. So I think you'll get that part at least, but usually we did not do, once again, if it's during the anesthesia before surgery and they let us know that it's happening, we'll just complete the whole spine because we don't know once we know that it's a low-grade tumor, I don't think we do it routinely.
Yeah,
I don't see the
I
reason.
know what you mean, because sometimes they can take up to an hour and a half just to do the spine, and radiologists don't like that very much.